With us is also Dr. Elizabeth Wangia. As I mentioned earlier, Dr. Elizabeth Wangia has been a technical lead in spearheading this process. Dr. Wangia.
Yes, Dr. Amina. I'm here. Yes, thank you so much, Dr. Amina, and for the organizers of this webinar. The CEO has given an overview of what SHA is all about, a bit around. My role, mainly for the purpose of this webinar, was to look at the benefits and tariffs. The first thing when people enroll into whatever form of insurance, whether it's life, motor vehicle, health, the first question they ask is, what are the benefits? So as a ministry, we knew that this is quite important. And therefore, we began the process of developing the benefits package. So first of all, you develop the benefits package, then you come up with tariffs. And tariffs are basically, the price attached to each intervention. The process of development of the benefit package is outlined within the Social Health Insurance Act and the attached regulations. There are three considerations. Anytime one wants to develop a benefit package, there are three things to put into consideration. The first thing is to look at what is the, so for the tariffs, what is the cost of the intervention? This is the benefit package and tariff. First of all, you look at the cost of interventions, then you do an actuarial analysis, and finally, you have to look at the budget, especially for social health insurance. You have to look at what is the available, envelope to cater for the services. When looking at the benefits, in this case for social health, for the social health insurance, we started by the whole universe of benefits. We have in Kenya, we have what you call the Kenya Essential Package for Health. So the Kenya Essential Package for Health basically enlists the various services and interventions by level of care, that is from level 2, level 3, up to level 6. What are the interventions that are available and considered essential? So that was our starting point. We looked at the essential benefits package. And when we did an estimation of the essential benefits package, we were actually getting figures of around 950. So the next question to be asked is then, now that we have the essential benefits package, and it's that much, and I'll also touch on how we got to say that around 750 billion. Then the next question is then, how do we prioritize? We know that in every situation, even our own salaries, we have to prioritize. So upon prioritization, we used quite a number of tools, including one tool from WHO called the DCP3 tool that really tells us what are those key interventions. Now that we had the whole universe of interventions called Kenya Essential Package for Health, through the DCP3 tool, we were able to see what are those interventions that are considered really critical for low and middle income countries to achieve UHC. And we went into further prioritizing based on that intervention. Thereafter, of course, we then did what we call the yield. I know the many people we have interacted with, know what the yield, because I said for you to develop a package with tariffs, you must know what is your budget, because you cannot put everything in the basket, and a package is definitely meant to be progressive. So we did our estimations, and when we considered the critical services and got our figures, we were able to see then with these figures, what will people contribute for them to be able to achieve this package? And that's how we landed on the 2.75 for all people within the formal and informal sector per household income. And therefore, with that, we now started putting detail into the package. So as in the process of developing the benefit package, of course, there are certain critical things that need to be put into consideration. One is that you must know your population in need. For instance, if you want to cover hypertensives, you must know what is the prevalence of hypertension, and of this prevalence, how many hypertensives actually know their status that they are hypertensives, because you could have a certain prevalence, but not many people know that they are actually hypertensive. Estimated number, and based on even data that we collected from literature, and even from, of course, literature studies and even prevailing data, we were able to know what does it take to treat a hypertensive, say in a year. What will it take to treat a hypertensive? That means on average, you'll have done your 3 monthly tests or 3 monthly reviews, monthly medications and all that. What is the average treatment per year? So if we got, say, 1 million, we realize that we have 1 million hypertensives who know their status, and treating them is an end. Therefore, for us to cover hypertension, we estimated that hypertension then will be that number of people multiplied by the cost of treatment per year. So we did that for all the diseases that we put into consideration, whether they were even immunization, family planning, normal deliveries, and we were able to get the estimated costing for that. Now, the other thing that we also need to know is that as we get the costing, or the costing, or I would say the tariffs, the next question we ask ourselves then, how do we pay the provider? Because the way you pay a provider has different incentives. If I say that all maybe payment methods is fee for service, and fee for service means it's actually what most people know in the private sector, that you come to the facility, you are charged for consultation. If you are doing a lab, you are charged for that lab. You probably are charged for the supplies. You need, a glove is used, the glove is charged, all that. So that method will actually be the ideal. But then in the situation where, say, we have, like, for instance, in the case of social health insurance, and even in private insurance, there are different incentives. So the provider or the clinician can decide to do as many tests as they want, even if maybe, I would say, quote unquote, they are not very, very necessary. And of course, we always say in the spirit of evidence-based medicine. Yeah, so maybe I have a flu. I can clearly, from the clinical symptoms, I see this person has a flu, but since I know that I'll be paid for every service I give, I will send them for a lab, for a hemogram, let's just check this in case, let's just check your lipids in case, all that. So that is the incentive. And as a social insurer, you cannot afford to lose actually resources in that way, because now that is inefficient use of resources. So basically, as we set the tariff, then the provider payment mechanism really has to be put into consideration. We know that NHIF mainly used to use capitation for primary health care. We know that capitation has limitations. So maybe for those who don't know capitation means that a certain amount is assigned to individuals. Like I would give like the NHIF case, an individual will select a facility, and a certain amount is given per head, or per belly button, as we used to like putting it. And these resources are given to a facility as a whole. And the assumption is that not everyone who has selected that facility will actually seek care. So the problem with this, so the advantage of this method is that then the clinician, since they know that additional testing and additional interventions won't earn them more, they tend to be more rational with their decisions. and therefore only make the only critical decisions for the patient. But on the flip side also, a facility can decide, now that I'm not given extra money for all these interventions, they can just do triage, say, probably take your blood pressure, blood sugar or something like that, and that is it. So there are all these incentives for the provider and also for the, especially for the at provider level. So so we have also other provider payment mechanism. There are those ones that are called case-based. And of course, like for us, one key method that, as I indicated, we will not use as a social insurer is the fee for service, except for specific interventions that you can clearly pinpoint to. So basically the process of developing the tariffs then we had around 6 processes. The first one was data collection and analysis, as I said, from literature review, and we're able to know what is the cost of offering primary level services. Once you do that data analysis and dispatch, then the next stage is tariff setting. Then once you have set the tariff, then we do provider engagement. Many times the people who we engage the most when it comes to tariffs are the providers, because at the end of the day, these tariffs will apply to them. And the question will be, do they make business sense to them or not? And therefore, if they don't make business sense, two things could happen. Is one, they could decide not to offer the service, or they could decide, or they could decide not to offer the service, or they could do what we call upcoding. So upcoding means that I have a normal delivery, but because the cesarean section is more expensive, I claim that all of my deliveries were cesarean sections. And in as much as maybe at that level of the provider, they may not think of the impact of upcoding, but at the end of the day, when you think of the whole research in terms of data analysis and all that, it then gives a skewed picture. And I'm not saying that that's what happened to this country, but I know in Kenya, the rate of cesarean section, in fact, there was an article, was it last year? There was an article that said that I think our cesarean section rate had gone up, I think, to around 20 or 25%. And probably that could be one of the reasons, because we know that there have been, Leader Mama has been there have been maternity packages, and if the rates are so poor, then people tend to think of a higher rate. The common one that I know people fall culprit to, maybe even if some surgeons are here, someone wants a circumcision and they just say, okay, phimosis, which is a medical condition. Then you end up paying for the phimosis, but it was just a circumcision. So probably at some point, when you're doing your analysis, you may be thinking, in Kenya, people really have this condition, but in the real sense, it's because the clinicians were upcoding the condition. So after provider engagement, and we had quite an extensive provider engagement, you cannot develop a benefit package without provider engagement, associations engagement, because at the end of the day, even at policy level, we cannot purport to know all the processes that happen for every condition in the country. So we really rely on guidelines provided by either the associations and the like, so that at least we can make reasonable sense. And therefore, without information, it's very difficult to develop a package or say whether we can afford it. A lot of experience I've got during this process is someone writes you a message and tells you, I want this service. Let me just say, why aren't you offering crutches? Then I just ask a simple question: how many patients need crutches in this country? Which conditions are documented that will need crutches? If you say maybe accident victims need crutches. Not all accident victims need crutches. Of all the accident victims, first of all, do we know the accident victims? Of all those accident victims, how many need crutches? How many would need crutches, and for how long? Because maybe some will need crutches, some will need a wheelchair, some, so now just delineating all that actually is quite some task, which really, I know a lot of times we had to actually send people out with this information, with this long template, and tell us how many people need this, of which condition, how long, what is the cost, and all that. So the good thing is that moving ahead, the law provides for a benefit advisory, benefit package, benefits and tariffs advisory panel. So the work of this benefits package, benefits and tariffs advisory panel will be to do exactly this throughout the year. If today you wake up and say, oh, I need sicklers are have not been covered and all that, so what do we do? Then you present intervention, give justification, give the data, say these are the number of sicklers. Of all these sicklers, these are the ones who will need bone marrow transplant at one point in time, and who are these who don't need, and all that. Then based on that, we see, yes, can we afford this? Or the cost of, then later on, when you look at the overall provide engagement, then the fourth stage will be around tariff recommendation, because we had quite some good actually engagements with the providers. We have we have the CHAC, which are the Christian community, who were really helpful when it came to this engagement and even tariff recommendation. So there are things that could happen. So for us, as we look at a tariff, we have our tariff as a social health authority. But then we realize or acknowledge that in every situation, people offer different things. So our tariff for us, we say if our normal delivery is this amount, whether you'll go to Nairobi Hospital or you'll go to Ruai or KNH, 30,000. Then if maybe for the private facilities who see that is not adequate, then we allow them to we allow the patients to co-pay. So for us, we'll say this is our commitment. Our commitment is 30,000, but because we also acknowledge that people go to hospitals to get things, there's also comfort in hospitals, and I don't think that the social health insurance would pay for, say, a couch or what. We're not saying that people should not be comfortable, but for us, we are looking at what does it take to offer that intervention. Therefore, we acknowledge that one reason or the other, there could be a reason for co-paying. And then also, so basically that is the tariff. Our tariffs are flat like that. 1 week ago, we managed to do a national validation for our tariff, and this week we'll be doing gazettement of the tariff. So that is just the process. Maybe also, Dr. Amina, you can guide whether there's an interest in maybe knowing what the tariffs are, what the package is all about. This was just basically the process.
Yeah, thank you, Daktari, for the summary. For us to understand what is benefits and tariffs, because majority of us do not have a good understanding of it. What I would suggest, Daktari, if you have if you have a short slide on the benefits and tariffs that are going to the benefits that SHA is going to provide together with the tariffs, and then after that we can go into Q&A.
Okay.
Is that okay?
Okay. That's fine. I can quickly just give me a minute to project it. Can project the benefits and
And what we can do in the meantime is perhaps answer one or two questions that were directed to the CEO. Dr. Wachira, you're still with us?
I am.
Yeah. So we have a lot of questions in the Q&A, and maybe I tackle the one with for registration. When I register for SHA, do I then stop contributing to NHIF? What does it mean registering on SHA?
Let me take that one. When you register for SHA, you do not stop paying for NHIF because NHIF benefits will be available up to the 30th of September. So if today is 10th of September, you have another 20 days. So for this month, the financier who will pay your hospital bills is NHIF. But with effect from the rollout of the SHA benefits, which is anticipated to be 1st of October, then you will pay for SHIF, be able to access SHA benefits. I hope that is clear.
Yes, that's clear. To me, we'll know from the Q&A if the thing needs further clarification. So, yes, Dr. I can see your slide is on, so we'll let you continue and finish, and then we can start the Q&A officially.
Yeah, so this slide basically just tells us of the process, what I indicated, how we identified the services, costing of the package and all that, getting the data till we computed the cost, determined the yield, optimized the package and validated with stakeholders. This one actually just emphasizes on what the CEO talked about, the 3 funds, which are now clear to all of us. So the benefits financed by the primary healthcare fund include outpatient services, meaning that if you go to an outpatient facility, you should be able to get the general outpatient services. You have a cold, you have a flu, you have, stomach problems. You should be able to get that service at primary level. And primary, when you talk of primary level, we're talking about the dispensaries and health centers, what we call level 2 and level 3. So at level 2 and level 3, we also have inpatient services. We know there are health centers and even some dispensaries who have, that one bed for the emergency. So overnight, we cater for that. Then screening services. Screening services will also be covered, and specifically screening for hypertension and diabetes. I will touch on maybe we had a expanded screening package, but we had limitation in resources. As I said, you have to look at the budget. Then optical services, that means if you have any eye conditions, include eye conditions, they are catered for under the primary healthcare. So the scope of cover is as I indicated. So when you go to a facility, you should be able to have the consultation, basic lab investigations. We know the lab investigations at primary level. Even most of the time, they are mainly rapid tests, but they're also, of course, the others. Imaging, prescription medicines, vaccines, outpatient procedures, management of mental conditions. If you have mental conditions, basically when we are saying if you go to the outpatient, we won't limit the condition or the diagnosis the doctor will give you. Now, when you talk about a tariff, as I said, it's the payment. Here we will be working on what you call capitation. We had, and this will, of course, eventually progress later to another payment method. But for now, as we start off, we'll start off with capitation. And capitation will be at 900 per person per year. Remember, we said that at primary level, we did the costing of services. One thing that we need to realize is that without costing of services, it's really difficult to know the cost of a service, because one person will be charging this high, another one this high. Then so we are saying at this level, so long as you are a registered member of the Social Health Authority, so long as you register, you don't have to pay, but of course we want 55% registration. But you're saying at this level, as long as you register and you are known to be a Kenyan, because the whole point of registration is to confirm that you are a Kenyan and that you are not treating, foreigners. Otherwise people will be coming in from even our border countries to seek services, and yet we have not planned for them. So under optical services, we are still talking about eye health education, eye tests, like visual acuity tests, whereas eyeglasses. And this one, we are working with 1,000 per household, per beneficiary. Then we have primary health care inpatient services. This one, I think I had mentioned that, so long as you're admitted, we pay what we call a daily rate of 2,240. And all this is based on the data that we collected. Like we knew what is the average length of stay of a patient in the ward. And based on that average length of stay, or they just within that average length of stay and did that per day. And I know that there are days probably that you spend more. Maybe the first day you're doing a lot of labs and all that, but probably after that it will be a matter of monitoring and continuing with the medicines so on. These rates are usually on average, and the limit is also on 80 days. So screening services, as I even indicated, that screening will be mainly for diabetes, hypertension, while the screening for the cancers will start in year 2. When at least, it's always good to be practical instead of starting so many things at the same time, which we may not be able to sustain. You'd rather start, slowly and progressively. And that's where we are. So for the Social Health Insurance Fund, those are benefits: outpatient, inpatient, maternity, renal care, therapy, mental illness, surgical services, oncology services, medical imaging, and overseas treatment. So for outpatient services, to start with, we'll be mainly catering for 4 main conditions: diabetes, hypertension, sickle cell, and asthma. And these are rates, tariffs per year. For inpatient care services, those are the rates. So basically, if you go and seek a service, this will be the rates per day, what you call daily rebate or per diem. It's not the usual per diem that we know, but yeah. So maternity, newborn, and child health services, we have right from the spectrum, right from conception till delivery, because we are looking at antenatal care and delivery, whether it's normal, cesarean, postnatal, immunization for the baby. In case a baby maybe complicates and needs to be admitted, then that baby will still be covered immediately under the mother or under their parent. For once, we are catering for anti-D serum, which was not there. We know anti-D anti-D is actually around 6,000. So it was almost impossible to offer this within the package, within the package, say, of Linda Mama, where for dispensaries we used to reimburse 2,500. And the anti-D alone is around 6,000. So for once, we'll cater for anti-D for rhesus negative mothers. And those are the rates for the normal and cesarean section. Renal dialysis, one thing that I would like to say, the renal patients are actually celebrating, well, not because of their condition, but because this time we know that there's been that need to have, say, a third session if a nephrologist deems it necessary. So in previously under NHIF, we were limited to 2 sessions of dialysis per week. But now we have brought in the third session when necessary. Then for the transplants, and mainly we know that mainly we do the kidney transplants, though there are other transplants. We have corneal transplants, liver transplants, but specifically, I'll just touch on the kidney transplants. For kidney transplant, for once we'll cater for the workup for the donor, the blood workups for at least one donor. Then after that, we also cater for the surgery of the donor, because for you to donate a kidney, of course, you need the surgery. Then also the surgery of the recipient. And we will also cater for the post-transplant immunosuppressants. And the reason why we are heavily investing in this dialysis is in the transplant is because this dialysis is one of the interventions that actually consume the fund. So you can imagine if you are being paid for 21,000 a week, that means per month the fund has to pay 80,000 per person, and therefore per year you're close to 100,000. So you can imagine, and dialysis is endless. Like, I mean, you can do dialysis of course, it will have to be for the rest of your life unless you get a renal transplant. And therefore, the investment in transplant is actually worth it, because within 3 years, we'll have no equalized, and starting with, I don't want it to sound bad, but I would say, quote unquote, our return on investment will be 3 years. Actually, it's around 2.5 years if we do renal transplants. Then I think this one I touched on this, the transplants. Then mental wellness is also catered for, and specifically here, allow me to touch on the drug and substance abuse, where we cater for at a limit of 7,000. We know that there are centers that cost up to 400,000, but then for us, what we can cater for is 67,000 based on the budget limits. Then of course, if there's the need for co-payment, the patient will co-pay. The scope of surgical services, we have the way we have put the tariffs for surgical services. It's based on a bundled, it's more of bundled. So we won't go and start counting how many minutes you are given oxygen in theater, how many hours did you, so how, rate per hour. No. For us, we say, what is the cost of an appendectomy? And we pay it as a lump sum. So that is it. And we have some accessories. For any insurance, there has to be the small print. Even in private insurance, that people don't read the small print. As we are saying, it's allowed. That there we have this in all this, and some of the small print is usually just to deter harmful behaviors. Hematology and oncology services for cancer. Also, cancer patients will get some reprieve with the social health insurance, where this time for diagnosis. So what could happen is let me say notice. So previously, what could happen is that you could be diagnosed, maybe you have a lump or something, yes, and ultrasound is allowed. Then that is catered for. But then now staging of the disease, now further tests to say, are you stage 1, stage 2, stage 3 was not catered for. So we had treatment. So in between here, patients had to either look for resources to fund that. But now we are diagnosis, staging, and treatment is allowed up to a limit of 400,000. So whichever cancer you have, the limit is what matters. So whichever protocol that will be used, and I know Kesho gave us a list of all the protocols per cancer, and those will be actually have been put within the system, so that we know that for this cancer, this is a potential protocol, and therefore we know the estimated costing for that. Medical imaging, MRI, CT scan, angio, Dopplers, mammogram, fluoroscopy, echo. PET scan is actually under oncology services, so we also have rates for that. Oral health services, we have the scope of cover is there. where we have screening, consultation, extractions, ART, dry socket debridement. Yeah, now that's not my really, my area, but we have all those that are covered. But the limit is 2,000 per household. And also for the areas where we have dental services available. Then overseas treatment, we are saying that overseas treatment, one will only cater for conditions that are not available in Kenya, and they'll be at around 500,000 per person. So for the emergency fund, right now, the main area that we'll be looking at, this is the range of services of benefits, but because of budgetary limitations, our main focus will be looking at comprehensive emergency services. That is a new service that was not there. So ambulance evacuation and stabilization of the patients within 24 hours will be catered for. Beyond 24 hours, the expectation is that if you have an injury, if you have another insurance, it will kick in. If you have social health, if you are a paid up member of SHA, that will kick in. Otherwise, for now, we want to cater for emergency services. And I know health generally sounds like everything should be an emergency, but for the purposes of this fund, we describe emergencies as conditions where if no interventions is done, I would say more or less immediately someone risks losing their life. So and that's why we say we pay for interventions that will stabilize someone, not really, make them recover, ensure that they are recovered, but stabilize them to a point of where we can say that this one can now live beyond, and that's why we say 24 hours. And this one will cater for services right from level 2 and level 6. Maybe you have eaten nuts and you are allergic and you into whatever anaphylactic reaction. You can go to your nearest level 2 because that is life-threatening. You can go to your level 2 facility. Fee for service for different conditions. And this also includes for feel relieved as they give the anti-rabies. For critical illness, this one will be covered at the normal rate as the normal inpatient, and it's solely because the budget was restricted. Of course, if once the fund grows and it gets into maturity, we actually know what the right rates are. But then for this case, any additional will be the patient will co-pay. Same with palliative services, be the same the same reimbursement as inpatient. And for the assistive devices, this one will also be rolled out in year 2. So cosmetic exclusions include, this is my last slide, I think. So exclusions will include cosmetic procedures, treatment by chiropractors, assisted fertility, vaccines other than those by KP, products out of the Kenya Essential Medicines list, weight management drugs, medical costs related to research, epidemics and pandemics, professional fees for medical personnel over and above prescribed rates, expenses related to diagnostic equipment, including but not limited to things like glucometers. So, I mean, if you're diabetic, we'll just treat glucometers. Any other procedure or intervention not listed in the scope of the benefit package. For the vertically financed programs, we acknowledge and we know that the good thing is that most of the donors, at least for the main ones, like for instance, even vaccines and all that, we know what are the outer years, I would say outer years finances. And therefore, this one, since they are already financed, then finance, because remember, if you put it in the benefit package and cost it, it means that a facility will draw a claim. But then now these ARVs have been given, say, or antimalarials have been given free of charge. So the facility cannot really launch a claim on that, but we acknowledge them, and we know that over time we need to absorb these services. Yeah, so I think that's where I am. That's where we are. Sorry, it took a bit of a long time. That's why sometimes I'm usually hesitant to present this, but nonetheless, I'm glad that I did. I hope that it has shed some light to the participants. Thank you. Back to you, Dr. Amin.
Yeah, thank you, Daktari. Thank you very much. I believe the slides were quite helpful. We could be able to visualize the tariffs and know the pros and the